patients are obviously really interested in how successful an ablation is going to be, and as the operator we're also interested in how successful an ablation is going to be. And the starting point for that is really, what are we trying to achieve in an ablation, or when we're managing AF? Generally we're doing an ablation in patients who are having a lot of AF and who are feeling it, who are feeling unwell because of it, or we're doing an ablation because the patients are having a lot of AF and it's affecting their heart function. So really what we're trying to do is minimize the amount of AF people are having so that they A, feel well, and B, the heart function improves. So that's the starting point. Historically, we've defined failure of an ablation as a single 30-second episode of AF. And that definition was arbitrary and arrived at basically for research purposes. You have to quantify recurrence somehow. But the reality is, if you're a patient who's having frequent episodes of highly symptomatic AF, and over the next 12 months you have a single 30-second episode of AF, you're very likely to be very happy with that outcome. You're going to feel radically different, and your heart function is virtually certain to improve. So we've made life difficult for ourselves when it comes to defining success. The way I tend to phrase it is that AF ablation works, but it's not necessarily a definitive cure. And we've got lots of evidence now that in the average patient who has an AF ablation, the amount of AF they'll have over the next 12 months is around 99% less than the amount of AF they'll have in the preceding 12 months. So whilst technically that may count in a research study as a treatment failure, in the real world, in the patient's lives, that's clearly a success. We do know that patients having an AF ablation may need more than one procedure. What we do almost universally in a first AF ablation is we electrically isolate the pulmonary veins. So the big veins that drain blood back into the heart from the lungs, we know that that's where AF is triggered from. So the aim of the game is to electrically isolate those veins. The main reason that some people have recurrence is that a small gap opens up in that ablation ring, in the ring of scar tissue that encircles those veins. And it turns out that roughly 30% of people over 1 or 2 years after an ablation will have enough recurrence to justify doing something different, and almost always the reason is that there's a small gap in that ablation ring. So at a second procedure, it tends to be a shorter procedure, and that's because basically what we're doing is sealing up that gap. So it's a relatively simple concept, and in some ways you can think of it as a continuation of the first procedure. It's basically to consolidate the gains made at the time of a first procedure. So when we're thinking about how many procedures a patient might eventually need, there's no defined answer, and there's no maximum number that any one patient may benefit from. In my head, I'd think about patients in two groups. There are patients who are having what we call paroxysmal AF, where the AF is coming and going. In my experience, those patients very rarely need more than 2 procedures. In general, if you effectively isolate the pulmonary veins, they do very well. And that's almost always able to be achieved within either 1 or at most 2 procedures. The second group of patients are patients with more advanced atrial disease, who tend to have much more persistent AF, much larger, dilated, scarred atria, often as a reflection of heart failure or other medical comorbidities. And in those patients, controlling the AF, it can still be really valuable in terms of making them feel better and improving heart function, but it is more of a challenge. And some of those patients may ultimately benefit from more than 2 ablations, basically because you're being a little bit more aggressive with the ablation strategy. You're ablating more tissue. Some of those patients may ultimately need other forms of procedures, pacemaker implants, resynchronization devices, and sometimes an AV node ablation where we accept the presence of permanent AF but seek to electrically detach the top chamber from the bottom chamber and let a pacemaker take over, activating the heart. So even beyond just an ablation, patients can end up needing multiple procedures of different forms, but still with the goal of making them feel as well as possible and protecting heart function. After those first few days, the main issue that we think about is the risk of early recurrence of AF. We know that can happen, and we also know that it doesn't predict AF down the track. Essentially, AF in that context is a reflection of the inflammation which the ablation itself causes, and that can be irritable to the heart. So that we've developed the concept of a blanking period, and this was again a sort of a research concept where any AF that occurred within the first 2 or 3 months after a procedure didn't get counted towards procedural failure rates. And essentially that is because we know it doesn't predict longer term AF. So early AF in the first 2 or 3 months may still need to be managed. Patients still may feel unwell because of it. They still may need medications or a cardioversion procedure, but it doesn't mean much for the longer term. So if someone's having symptoms of AF in the first couple of months after an AF ablation procedure, we handle it the same as we would any other AF. So if you're feeling unwell, contact your GP, contact the AF Institute nurses. In more extreme cases, if you're feeling really unwell, come to hospital. So after an AF ablation, my approach to management is I don't stop antiarrhythmics. I certainly don't stop blood thinners, because in fact we know that the first couple of months after an ablation are, first of all, a relatively high risk time for a stroke if you're not on a blood thinner. And secondly, that you may still have episodes of AF that are a result of the procedure and in fact don't mean much for the future. So I try and stop antiarrhythmic medications perhaps after 3 months, but certainly not in the first couple of months. And in fact, if you are having episodes of AF in those first 3 months, it's important to not worry too much about it, to recognise that it doesn't mean the treatment hasn't worked, it doesn't mean much for the future. We would manage that AF as we would AF any other time. We're focused on making patients feel well, protecting heart function. So we don't need to rush to do anything differently, but if you're having AF that lasts for more than 24 or 48 hours and you're feeling unwell, we might need to change medications, we might need to organise a cardioversion procedure. So certainly contact your GP, contact the AF Institute nurses, and we'll develop a management plan.